First up, I'd like to introduce Professor Askenazi, who's going to speak to us about adenosine antagonists and the kidney.
Thank you, and thank you, Ravi, for this opportunity to talk a little bit about a topic that we've been learning about in neonates, and I want to be able to share that here with you. So I'm going to talk about adenosine antagonist and its potential role in the prevention and treatment of acute kidney injury. Let's see. There it is. Here's my disclosures, and they do not have any influence or pertinence to this presentation. So I want to acknowledge Matt Hare, who is a neonatologist that's done a lot of this work, and he helped make some of these graphics through ChatGPT as well as the content of these slides. So I want to acknowledge him. So what are methylxanthines? They are a purine-derived group of pharmacological agents that have been used in clinically, and you probably consume them on a very regular basis. They're non-selective antagonists of adenosine receptors, and the complete mechanism of action is still being discovered. And the medicines that we use or the consumptions that you have are caffeine in different forms, as well as theophylline, aminophylline, and several others. So how do they work on the kidney? This is actually a paper from 1864 that talked about caffeine and its role in patients with congestive heart failure and documentation that they instill diuresis. And if you're a coffee drinker, you know this to be true. And so the other ways that it works is by inhibiting the adenosine receptors, its major effects are diuresis. It has an important role in natriuresis, including multiple electrolytes, including sodium, chloride, as well as calcium and magnesium. It has hemodynamic effects by increasing renal perfusion, and it has a role in increasing renin. It also has been shown to reduce oxidative stress, maintain mitochondrial function, and inhibit endoplasmic reticulum stress. So all this together brings us to the topic of today is let's talk about how it has been shown to be potentially preventive and therapeutic for sick newborns. So in the United States, 4 million babies are born, and approximately 8% are admitted to a neonatal ICU, which if you do the math, there's approximately 300,000 babies admitted to the NICU, and neonates represent approximately 5% of all ICU admissions to the United States. So we performed a study called the AWAKEN study, the assessment of worldwide acute kidney epidemiology in neonates, that we published the epidemiology in 2017, where we found that of a selected group of patients, mainly those that were the sicker half of the NICU population, based on the requirement of needing IV fluids for at least 2 days, approximately 30% developed at least one episode of acute kidney injury. And not surprising to us or people in this group, those that had acute kidney injury had a significant higher mortality rate on the order of 10% versus 1.4%. And when you do the statistical analysis, accounting for multiple other potential variables that are known to be associated with mortality in this population, the adjusted odds ratio was 4.6. And it had a significant increase in the likelihood to remain in the hospital for a long time. This data has been now confirmed through a meta-analysis of over 100,000 patients, 201 studies that was recently conducted, where amazingly found the same incidence that we found in AWAKEN at 30% and an adjusted odds ratio mortality of 3.4. And it's been shown that that's applicable in any continent and very similar rates across both high-income countries as well as those that have less income. And so back to the methylxanthines in use in babies, these are actually very common, and many babies, most babies, premature babies, receive either one or another type of methylxanthine for the purpose of keeping them awake. So premature neonates tend to fall asleep to the point that they stop breathing. And so this actually stimulates them and helps them remember to breathe. And so this is very commonly used. There's tons of data on its safety in neonatology, and it's been used for over 40 years to treat apnea of prematurity. Most of the initial use was with theophylline or aminophylline, but it has really switched over to caffeine, and there's a huge rise in the 1990s. And as I mentioned, most programs are using caffeine for a vast majority of their babies. And so do methylxanthines then prevent acute kidney injury in both term babies and who are born with perinatal asphyxia and hypoxic ischemic encephalopathy? That is the first question to address here. There's been very nice studies that look at the pharmacokinetics of theophylline in the context of acute kidney injury, and not surprising to this group, you'll know that they need a lower dose to remain in the therapeutic range because of the decreased clearance that happens when you have acute kidney injury. And studies have now been done, including these 7 randomized clinical trials that were performed in the 1990s and 2000s that captured up to 450 asphyxiated newborns and have shown a significant improvement in the odds ratio of acute kidney injury in those that were randomized to these medicines, mainly theophylline and aminophylline, with an odds ratio of 0.2 to acute kidney injury, although there was not in this meta-analysis an improvement in mortality. It's been shown to lower creatinine, improve urine output, and decrease length of stay. And in fact, based on those studies in the 2012 KDIGO that we're all very familiar with, which we recognize do not have many or any therapeutic recommendations, do state that in premature in term neonates who are at risk for acute kidney injury, that it was felt to be a significant high enough data to suggest that it can be and should be used in this population. But unfortunately, or perhaps because people are continuing to be skeptical, this practice is not really done across the world or even in my center because of several concerns. One of them being that the standard of care has changed in that most of these babies are getting hypothermia as a therapeutic hyperthermia. And so the question of, well, is this still applicable, still is out there. And there's questions about, well, is it enough to improve someone creatinine to make a recommendation that all babies should get it? We likely need some longer term data to show that it improves either survival or chronic kidney disease or other hard clinical endpoints. But nevertheless, KDIGO does recommend its use. What about AKI prevention in premature neonates? This is data that was first published by the group in Virginia, Jennifer Charlton and Brian Carmody, that looked at a retrospective cohort study of 140 very low birth weight neonates. And what they were able to show was that those that were exposed to these medicines, to caffeine, had lower rates of acute kidney injury and lower severity of acute kidney injury, with the number needed to be exposed to prevent one episode of AKI only 3. But the concern was that this study was not large enough to try to control for whether the babies that were received caffeine had lower severity of illness. And so in the Awaken study that I previously mentioned, we had 675 premature neonates. And so this was an opportunity to look at that. And indeed, we found not only a lower rate of acute kidney injury and less severe acute kidney injury in those that were exposed to caffeine. But surprisingly to us, those that were receiving the caffeine were actually sicker patients. And so if anything, these were selected to the sicker babies who you would think would have more acute kidney injury. And our odds ratio was 0.2, with the number needed to be exposed to prevent one episode of acute kidney injury. Again, a very low number of only 4. And here's the statistics looking at kind of the adjusted odds ratios for not only those that were very severe, extreme premature neonates, but also the moderately sized premature neonates, and look at its timing as well, whether it was given early in the course of their life or after the first week. And in fact, now there was a meta-analysis done on these 5 studies that, again, showed very similar findings, looking at prospective observational cohorts, again, of 500 patients. And again, neonates that were exposed to caffeine had a significant lower rates of acute kidney injury. We also took an opportunity to look at and ask the question of whether neonates who were exposed to caffeine had different 2-year kidney outcomes in a study called the Peanut Trial. And in this study of premature infants born less than 28 weeks, we did not find that there was a difference in their prevalence of chronic kidney disease. We did see in a sub-analysis that in babies who had chronic lung disease, we did see an effect of caffeine on its impact on blood pressure and chronic kidney disease on that subset of patients. And it's important to recognize that not all studies have been positive. There's single-center, double-blind, placebo-controlled randomized trial of a small cohort of kids that looked at theophylline versus placebo and did not find a significant difference in AKI severity. And in a single-center phase 1 clinical trial randomized a very small number of kids of 17 neonates that received theophylline versus placebo did not see that. And again, so these are small studies, one in neonates undergoing cardiac bypass surgery. Importantly, in that study on the left, those patients were received the drug 6 hours after cardiac bypass surgery, posing the question, well, what would have happened if you would have given it before the surgery or maybe around the time, shortly after the surgery? Now, there's certainly lots of opportunities coming forward. The Neonatal Kidney Collaborative, which is a collaborative of neonatologists and nephrologists, have recently advocated for more systematic adoption of kidney metrics in large regional and national databases and randomized clinical trials. So this, I think, is going to provide us a lot of opportunities to mine, massive databases to try to see what we find there. And there's several different other opportunities that remain. There is currently ongoing studies looking at the timing, dose, and duration of these medicines in context of hypothermia. And there's also a pilot trial looking to try to optimize the timing and the pharmacokinetics in hopes that we will then be able to perform a large multi-center randomized clinical trial in babies who are receiving hypothermia and to determine its effect. The other thing that's happening through the Neonatal Kidney Collaborative is this study called Awaken 2.0, which we're really, really excited about. It's led by Michelle Starr out of Indiana and in working with David Slutsky. And this study is now active, and we have 120 plus centers in over 35 countries committed to the study. And certainly one of the things we're going to be looking at is this question in neonates. So in conclusion, methylxanthines have the potential to improve neonatal kidney outcomes. More research and more studies are needed to better understand its effect. And certainly lots of questions arise, including, its dosing, its timing, and then certainly questions about, well, does it potentially improve outcomes in children, and what about in adult populations? So with that, I thank you very much, and I don't know if we're taking questions.